Welcome, everyone, and looking forward to hearing all about Stop the Poke. It's really a nice idea for some of our diabetics. So welcome to attending our session, and you're going to learn a lot about continuous glucose monitors and what they're all about. You may have seen some from your patients. I know I have, as patients come into the office, sometimes wearing these gadgets. We have two great presenters who you may or may not have heard present before that are going to be with us through the evening. And I'd like to introduce them to you. One is Dr. Rose Yeung. Rose is an associate professor of endocrinology and metabolism at the University of Alberta. She's a clinician researcher as an endocrinologist, as well as a health services researcher. And she's interested also in quality improvement, and particularly around diabetes. Her clinical practice is focused on type 1 diabetes in pregnancy. She's also a member of the Alberta Diabetes Institute and is a senior medical director of the University of Alberta's Office of Lifelong Learning, which is a key element to bringing these excellent presentations to you. The other speaker that you'd like to hear about is Dr. Darren Lau. He is an assistant professor in the University Alberta Hospital, as well as at the K Edmonton Clinic. He's a diabetologist, similar to Rose, a general internist, as well as a clinical epidemiologist. Apart from his research and outcomes on medical therapy in adults and diabetics, he really enjoys sharing the newest things about the gadgets and things in diabetic care with anybody who will give him the time of day. And thank goodness for that, because we're going to hear a lot about that. We would like to acknowledge that we are on traditional territories across Canada of many of the First Nations, Métis and Inuit, whose footsteps have marked these lands for centuries, and may we care as well of this land as they have. Now, we do have a poll, and we'd like to know how prepared you are to interpret a patient's continuous glucose monitoring output and give them advice on things they can do differently. You know, so are you very prepared, or can you do it if you're pushed? Or what is continuous glucose monitoring? So put in your answers. And we have about 23% that are very prepared. 60% can do it if they're really pushed. And then 17% say, you know, what is continuous glucose monitoring? Well, we'll have some experts take it away for you.
I appreciate the honesty for that last, those 17%. I guess we'll do our disclosures quick. So I guess I'll do mine and then I'll let Rose do hers. Again, thank you so much for the introduction, Dr. Manca. My name is Darren. I'm a general internist at the University of Alberta Hospital. My disclosures are up on the screen there. I have not received any consulting fees or funding from pharma. although Abbott Laboratories, which happens to be the manufacturer of the FreeStyle Libre CGM device, is providing some in-kind support for one of the randomized trials that you'll hear about later that I'm currently running. Okay, Dr. Yeung.
Thank you. And so I'm Rose Yeung, and my pertinent disclosures relate to the same trial. So that's it. And I have not been a paid speaker for any continuous glucose monitoring devices. So we'll move to the next page.
Okay, again, it's my pleasure to be here today with Drs. Yeung and Manca to talk to you about continuous glucose monitoring. This is what we're going to try to cover today in the next 50 minutes or so. Thing number one, we're going to describe what CGM is and a little bit about the evidence for its use. So getting at the question of why you should use it too. Thing number two, we're going to demonstrate an approach to reading CGM data and providing advice to your patients based on CGM data, but more importantly, having conversations with your patients about their CGM data, which is probably the most important thing to get out of CGM. So addressing the question of how you should use CGM in practice. And then finally, we're going to talk to you about some research opportunities that are up and coming, and a bit of a plea for assistance in terms of finding patients who might be appropriate for a couple of studies that, that we're going to go over. All right, Dr. Yeung.
So thanks. So continuous glucose monitoring really, I think, has been one of the most amazing technological developments in the field of diabetes care. And the analogy that Peter Sr. likes to talk about is making it akin to driving a car down a road. And typical capillary blood glucose monitoring is basically taking a picture of the road, riding in a blacked out, you know, the car windows are all blacked out, and you're only getting a picture of that road every few hours whenever you're testing. Whereas continuous glucose monitoring is basically unblocking out the windows, actually being able to see out the windows and look ahead and see the road and be able to anticipate what is coming with that visual help. And so one of the other considerations around continuous glucose monitoring that's really important to consider is that we have traditionally been using A1C as our major surrogate marker of diabetes control or glycemic control. But I think this is a very telling picture where this shows you 3 different profiles of people, all with an A1C of 7%. And yet you can see that the time in range, or the time in desired range, is quite variable. And so you can see somebody could be 100% in range, somebody could be 25% high, or somebody could be having both highs and lows and being on that roller coaster of glucose, feeling very unwell, but still having an A1C that is what we would consider at target. So it's really important to realize the limitations of A1C and that it is not the be all and end all. And we have to be aware that we are now moving towards this language of time and range and understanding the glucose ups and downs in more fine detail now that we can. So the Diabetes Canada guidelines released a 2021 update on blood glucose monitoring. And we now have these 3 terms that we want to use more regularly, which is capillary blood glucose monitoring, or CBGs, for the standard finger pokes, which were previously known as self-monitored glucose, or SMBG, using the sticks. Now we are talking about intermittently scanned continuous glucose monitoring, or ISCGM. The previous term for this was the flash glucose monitoring, using the interstitial fluid for measurement. And this is, of course, using the FreeStyle Libre 1 or 2 devices, and soon to be Libre 3 down the road, hopefully. And now we use the term real-time continuous glucose monitoring, or RTCGM, which is previously known as just CGM. And this is also using interstitial fluid via sensing device that continuously transmits the data without having to scan. And so we have two available devices in Canada, the Dexcom and the Medtronic real-time CGMs available. So just to give you a bit of a diagram, this is the sensor that sits atop the skin, and it has a filament that sits in the subcutaneous space where it measures the glucose from the interstitial fluid. And so this here is the FreeStyle Libre, this is the Medtronic, and this is the Dexcom device. And you can see here that in the ISCGM, the sensor is scanned with a reader or a phone. And in real-time CGM, the person wears the sensor it's also got a transmitter, which then sends the signal to the device that could either be a cell phone or a receiver, or in some cases, insulin pump. So I've created a little table here just to summarize the major features between these devices. So you can see that the sensor wear time varies across the different devices. The Medtronic is the shortest at 1 week, and the longest is the Libre at 14 days. And the real-time CGMs are both integrated with pumps, and whereas the Libre is not integrated with the pumps yet. However, in the US, it is integrated with the Omnipod pump. The accuracy of these devices is improving, and you can see that they range around 10% or less, which is really, really quite good, considering that when you look at the standard glucometers in Canada, Health Canada actually accepts devices that are within 20% accuracy. So having 10% accuracy is actually very good. The average cost is a big challenge for many patients who do not have private insurance or coverage. And per week, it can be anywhere from $50 to over $100. The need to still poke is still required for the Medtronic, but it is the accuracy is improving on the Dexcom and Libre, so it is not needed as frequently, but we always counsel patients to check when they feel there is a discrepancy between what the reader is saying and how they're feeling, or if they want some additional reassurance with what the number is reading, they should check again and check with the standard glucometer. There are different sites approved for where people can place these sensors. And all of these devices have different functions with regard to alerts and alarms, as well as enabling data sharing with others, which is really, really important when people have things like hypoglycemia unawareness, or children where parents can check blood sugars remotely, or partners can check blood sugars remotely if there's concerns about hypoglycemia or sustained hyperglycemia concerns. So in the Diabetes Canada update, recommendations are made for real-time CGM with regards to encouraging all people with type 1 diabetes to access these devices and offer these devices, as they have been shown to reduce A1C, they reduce hypoglycemia, and also the distress that occurs with hypoglycemia. They also increase time in range and quality of life. When it comes to people with type 2 diabetes on multi-dose insulin, these devices have been shown to reduce A1C and hyperglycemia, as well as increase time in range. And What's really impressive is that in pregnant patients with type 1 diabetes, there's even been shown to have significant and cost savings reductions in neonatal ICU admissions, as well as decreasing large for gestational age rates and the rates of neonatal hypoglycemia. When it comes to the intermittently scanned CGM, there's good data showing that in type 1 and type 2 diabetes on insulin, there is reduced hypoglycemia as well as increased time in range and increased treatment satisfaction. And when it comes to pregnancy, there is good agreement with capillary blood glucose testing in type 1, type 2, and gestational diabetes, and high user satisfaction. So it is really important for us to get a better understanding of these devices and to be offering patients more routinely, if they are insulin especially, access to these devices as standard practice. So obtaining continuous glucose monitoring data can be done a couple of ways. So the patient can just show you directly on their device. They have access to certain reports on the apps that come with these devices. The other thing is that if you see a number of patients or have a certified diabetes educator or a chronic disease nurse or healthcare provider who's helping you out, and you want to be able to obtain these records as a routine basis, please contact the company directly for support when it comes to downloading the software and going through a tutorial of how to enable your office or your clinic setup to obtain this data. So the approach to understanding one of the key features of glucose data is now this report called the Ambulatory Glucose Profile, or the AGP. And we're going to get into what the AGP is. But basically, it's a way to standardize glucose data so that it is easily interpretable, much like an ECG standardizes cardiac electric signaling. The AGP is meant to be that quick snapshot that you can look at and quickly interpret. So the AGP consists of 14 days of CGM data, and it has been shown to correlate well with 3 months of CGM data when it comes to glucose, time in range, and hyperglycemia measures. There is something called the Glucose Management Index, or GMI, which is basically an estimated A1C. And there is this variable now called time in range with agreed upon categories that we're going to show in the next slide. There is also a way to understand glucose variability, so that up and down factor, and that is now reported on the reports. So these are the time and range targets as determined by a consensus group that included people with diabetes, as well as experts in diabetes care, both from the medical and the research side. And so now the current targets are moving towards being more than 70% in range, as noted by 3.9 to 10 millimoles per liter. And then we've got level 1 and level 2 hyperglycemia here, and level 1 and 2 hypoglycemia marked here for reference. And of course, like A1C, we also want to be aware that our time and range targets may have to be modified for people who are more frail or at higher risk of hypoglycemia. So we may tolerate more hyperglycemia in those patients. So now I'm going to pass it over to Darren to carry on.
So in the following, what I'm going to do is show you a little bit of some approaches you might take to analyzing the data you get from a CGM report. But I want to be very clear. The point is not necessarily to memorize and walk through the 9-step approach shown here, for example, or even the simpler 3-step approach I'll show you later. The point is rather to use the principles from these approaches to have conversations with your patients. And what I'm going to do after we go through this slide in just the briefest of ways is we're actually going to look at some real CGM data from a patient with type 1 diabetes and go through an interpretation. So anyways, what you have in front of you is a 9-step approach. And this was developed by Rich Bergenstahl out of the International Diabetes Center out in Minnesota. And if you ever want references for what is probably leading edge in terms of interpreting and understanding these devices, International Diabetes Center is a fantastic resource, but we'll have other resources highlighted at the end of this talk too, including some local diabetes educator groups who have put together some beautiful resources to help out with these sorts of things. But anyways, okay, the 9-step approach. Step 1, very much like interpreting a chest X-ray or an ECG, patient name, etc. But is the data adequate? So is there more than 70% of the sensor time reflected in the data? Do you have the full 14 days worth of data? Step 2, know your patient. So what are your patient's patterns and how are they reflected in the data in terms of when they wake up, their meals, etc. 3, and I bolded this one because this is, for me, the critically important one is once you sit down and look at the information with your patient, what does your patient think of all this? Step 4, discuss hypos, always hypos. Step 5, then you discuss the highs. Step 6, look at variability, and we'll talk about what variability looks like on CGM reports. Then step 7, if you have the luxury of having had a previous CGM report, have a look at that. If there's anything that's improved, make sure you point that out to your patients. I don't know that we as diabetes people do enough positive reinforcement. Step 8, create an action plan with your patient based on the information. And then of course, step 9, document things. Okay, that's enough of that. Let's go on. So the patient is a 43-year-old female, physically active individual with type 1 diabetes. This is actually a case that came from a diabetes educator at a previous talk that Rose and I had the honor of presenting at. So it is a real patient, although it's not one of mine. Okay, this individual with type 1 diabetes is on Tresiba or insulin degludec, 18 units daily, Novorapid or insulin aspart, 4 to 6 units with breakfast, 1 to 2 units at lunch, 1 to 2 units with supper. She also takes dapagliflozin 10 milligrams every day, and she goes to the gym about 5 days a week between the hours of 4:30 p.m. and 6:30 p.m., a combination of cardio and then some resistance training as well. Her HbA1c is 8.3%, and she appears in clinic with her CGM report asking for, well, doc, what's up next? So this is a CGM report. I'm going to show you bits and pieces from a CGM report. As Dr. Yeung was alluding to, all the reports these days have some degree of standardization because there is a common format with common metrics that's been agreed upon at the international level. This particular report happens to be from a FreeStyle Libre 2 and is presumably either pulled off of LibreView, for example, which is the online cloud-based portal for generating these reports, although there are other ways of generating a report like this. Okay, so on this page, you see just some summary stuff. And the summary stuff, the first thing I look at is, okay, so is the data adequate? So I can see there's 14 days worth of data here. And then the sensor is active more than 70% of the time. So yes, these data are pretty good. Okay, I'll go to the next slide. There we go. Okay, then I like to look at time in range, right? And I don't know, Rose, if you could highlight the green bar and the time in range. So that green bar represents the amount of time, the number of minutes every day that patient spends with a blood sugar between 3.9 and 10.0. And then that's the target range. This patient's time in range is 32%, okay? And if you want to know what the targets are, it's very convenient. This particular report has the targets provided on a panel on the left-hand side. And you can see the target time in range is greater than 70%, as Rose mentioned earlier. You can see time below range, so time in range TIR. Time below range, TBR, is the time spent in hypoglycemia. And the target for that is level 1, level 2, cumulatively less than 5% of time. And in fact, this patient has 1% of time with level 1 hypoglycemia. That even 1% of the time, though, that's about 14 minutes out of the day. So actually, you know, I know that's within target, so to speak, but it's still worth poking into, and we'll discuss that a little bit later. But this patient's big problem, according to this time and range chart, is that she spends most of her waking minutes hyperglycemic, level 1 or level 2. Actually, she's very high with a blood sugar that's more than 13.9 millimolar per liter, 42% of the time. Okay, so this gives you a pretty good snapshot of what's going on, what the clinical issues might be. There are some other summary metrics that this page gives us. So I'll take the next page. Okay, this is the glucose management indicator, that 8.9% that Rose had introduced earlier. Again, this is what the computer thinks the HbA1c would be based on the last 14 days worth of interstitial glucose measurements. In this case, it's pretty close, 8.9%. This patient had a venous A1c of 8.3%. But there are cases where it might actually be more accurate than the venous A1c. And so, for example, this might be in your patient with anemia. Maybe they have hemolytic anemia and their venous A1c is actually lower than it should be because of high cell turnover, or low cell turnover if they're anemic from chronic kidney disease, then the A1c by venous draw would be too high. So you might actually find the glucose management indicator a more accurate representation in that case. And it might also be a bit of a better measure if you've just recently made a therapeutic change within the last 3 or 4 weeks, and the venous blood A1c is not going to represent that yet, but the CGM, GMI would actually represent that. So there are some instances where you might actually prefer this glucose management indicator to a true HbA1c. The other metric that's here is glucose variability, that 38.2%. And this number is a coefficient of variation. So it's a statistical quantity. It's the standard deviation of blood glucose, or interstitial glucose measurements rather, divided by the mean measurement. And for reference, because as a percentage, it's a little bit meaningless. You have to take it with respect to your target. And so for reference, we consider less than 35% to indicate relatively tight blood sugar. Is not a lot of variability. Above 35% is indicative, okay, there's variability here now, what's going on, right? All right, so this is some of the summary at a glance statistics you can get from the first page of most CGM reports. All right, let's take the next page. Now, this is where I think the money really is at, okay? This is the ambulatory glucose profile, and it shows you what the patient's blood sugars, or interstitial sugars to be more precise. I'll use those interchangeably as we go along here. It shows you what the patient's glucose values are at any given point of day during the last 14 days. It tells you what the median blood sugar at that time was. It tells you what kind of spread you see around that median value. So the interquartile range in the darker blue, and then it tells you what the extremes are. So there's a 5th percentile and a 95th percentile that's provided too. And I'll tell you, the ideal AGP in a very well-controlled patient is actually gentle, smooth, flat-ish, and falls mostly between those two green lines, 3.9 millimolar per liter, 10.0 millimolar per liter blood sugar, right? And so that's the ideal target AGP, is a nice smooth river, okay, a relatively narrow one. Now this AGP, you can tell right away, it starts in the wee hours of the morning, relatively narrow. Then as you can see, the day goes on, it becomes wider and wider. The patient spends most of the waking hours being quite hyperglycemic. It looks like a river that's going to overflow its banks, right? This is a wide and wild river. And this is an example of an AGP that has a lot of hyperglycemia and a lot of variability. So kind of the opposite of what we're looking for, what we're trying to get patients to. There's one thing that's really important when I look at AGPs like this is variability. And so variability, you can look at the coefficient of variation, but I think it's really important just to look at how wide some of these intervals are. Look at how wide that interquartile range is in the evening, for example. And the problem with variability is, yes, this patient is hyperglycemic. She spends a lot of her evening, her afternoon time with blood sugars that are well above 10.0. But if I were to, for example, tell her to increase her insulins across the board, and if she were to push this AGP, this river downwards, because it's so wide, you see that a lot of that time would then be spent with borders that are under the 3.9 mark. So I would be pushing her into hypoglycemia by doing that. And so that's the problem with variability, is that it indicates a lot of factors that need to be investigated, that need to be sussed out with your patients and addressed, but it also indicates a certain amount of hazard in lowering blood sugars, right? Okay, I'll take the next slide. So when it comes to this specific patient, there are two insights that you kind of get from this AGP. The first one is this very consistent overnight trend where she starts her night with a really high blood sugar, and very consistently her blood sugars inexorably just go down and down and down throughout the night until she wakes up. And you can see that she spends some of her time at that point hypoglycemic, because you can see that 5th percentile line dips below 3.9. Okay, so from this, you might generate the hypothesis that I think this patient is on too much insulin degludec, right? She might be over basalized. Okay, too much basal insulin. So that's one thing you can get out of this AGP. The other thing, of course, is that she's very hyperglycemic and has a high degree of variability in the afternoon through the evening. So that tells you, well, you just got to talk to your patient and see what's going on during that time. There's some conversations that need to be had. Okay, I'll take the next slide. So after looking at the AGP, now it's time to flip through some of the daily glucose profiles. Sometimes you see summary graphs like this showing all the daily profiles in the last 2 weeks in little tiny boxes across 2 different lines. I really don't like looking at them this way. The only value to me of seeing this display is it provides at a glance information if there's a whole bunch of missing data, big breaks in the spaghettis, that sort of thing, for data accuracy and adequacy. I don't make too much of it because it's really hard to interpret things when they're squished down and every peak and valley looks like a mountain, right? So let's go to the next slide. So this is some of the daily glucose profiles. I call them spaghetti diagrams. I don't know if that's necessarily an approved name or a marketed name for them. It just makes sense. They look like spaghettis, right? You can see I provided some examples here from a couple of days in February. And this is, if the AGP for me is hypothesis generating, then the spaghetti diagrams is where I go to confirm hypotheses, right? And I had this idea that if I were to look at her AGP, of course, is not actually my patient, but I would have this idea that she was over basalized, and this would definitely confirm it, because you can see on the Friday, she starts her blood sugars overnight quite high. She drops, and actually she becomes hypoglycemic, right? This is not the only day in the data that she does this. So yeah, definitely too much Tresiba. But the fascinating thing about these daily profiles is you can see that little circle just above the 2.6 where she's hypoglycemic. That indicates she took a measurement at that time, okay? And that measurement put out a result of 2.6. So I can tell that she was probably symptomatic around 5 o'clock in the morning, maybe 5:30, woke up, measured with her Libre, knew that she had a blood sugar of 2.6, and then she did something to fix it, because then her blood sugar shoots up, right? In fact, she probably overdid it, because then she became very hyperglycemic. And when you talk to your patients with that degree of specificity, I gotta say, a lot of my patients look at me like I'm a Jedi, right? They look at me because I've literally gone back in time and read their minds, and they say, yeah, actually, that's exactly what happened. They might not have even remembered it because it's maybe, a week and a half ago. Who remembers what they even ate 2 days ago, right? But they might not have even remembered it, but then you mention it to them, you say, I think this is what happened overnight. And then, oh yeah, that's exactly what happened overnight. And I really love those little aha moments you get when all of a sudden it makes sense to the patient. That's what's been going on, right? But anyways, so yeah, I think this is kind of confirmatory that we were on too much degludec here. Okay. So to look at some more of the spaghetti, you can see that night actually around 8 p.m. the blood sugars suddenly shoot up, okay? So I do wonder when I see that whether she's anticipating that she's gonna run low overnight and driving her blood sugars up deliberately before bed. So this habit of quote unquote feeding the insulin, right? And so that's something that could be addressed. And then the weekend though looks pretty good. Like the Saturday, yeah, that looked pretty good. The Sunday, yeah, that didn't look too bad, right? Compared to we're going to see some other days actually, compared to some other days. So, this kind of implies that the patient actually does have things under control on the weekend. There's something about the weekday specifically that cause a lot of trouble. So that's kind of telling. Okay, I'll take the next slide. All right, so this is some weekdays. We got Tuesday, a Wednesday, we got a Thursday. You can see, yeah, the numbers all over the place. This is the high variability time, right? So you've got blood sugars that shoot up at 3 o'clock in the afternoon. Sometimes the blood sugars shoot up a bit earlier and they stay up and down, but they stay up, right? And then at other times they kind of fall right down. Whoops, I realize now that you can't see my mouse cursor. I hope my description of those spaghettis and what I'm referring to is obvious. So when I look at on the Tuesday there, so the first day's spaghetti here, you know, I recall, look, her gym time is between 4:30 and 6:30 in the afternoon, and she happens to be quite hyperglycemic that Tuesday around that time. So that does make me wonder whether the patient is again concerned about lows and perhaps really taking short-acting carbohydrate and driving those blood sugars up. I know also that she's only on 1 to 2 units of aspart with meals during the day, although she takes a lot more at breakfast. And so again, I wonder if there's some deliberate attempt here to keep the blood sugars higher to avoid hypoglycemia, right? Yeah, so all in all, I think there's a lot of fodder for discussion here to try to tease out what's going on and what might be done to help sort it out, right? One thing I do note is that her blood sugars can go down pretty rapidly, right? And that might be because of insulin or physical activity, or it might be because she's driving her blood sugars up with short-acting carbohydrate that then leaves her system. But a lot of this indicates the absolute need for alarms. And one of the nice things about Libre 2 or the other CGM devices is they come with alarms now. And so I do encourage my patients, hey, you should set your alarms. And I make sure they have their alarm set, because that can give a lot more confidence to start doing things like revising insulin or trying to avoid feeding the insulin, et cetera, if the patient's confident that they're going to know when they run low even before they have the symptoms. So I can't emphasize how important, what a big change it was to get alarms with something like the Libre 2. Okay, so talk to your patient. To summarize this patient, if you look at the Libre data, what you see here is a classic picture of over-basalization, a bit of over-treatment of the low and then over-treatment of the over-treated lows. So on some of those days, you can see the roller coaster of blood sugars, right? And some evidence that the patient is probably running higher and more variable blood sugars on gym days because she's might be, for example, anxious about lows. All of this, of course, you can conjecture, but you really have to have a conversation with the patient about it. In terms of planning based on these data, you probably need to, you could plan to reduce the degludec, probably needs to have the breakfast aspart revised. It's a bit high compared to lunch and supper doses. And you could do that incrementally by making little adjustments, or you could do that wholesale by saying, oh, I'm just gonna clean the slate and redo your insulin prescription based on your weight, using 30 to 40% as the total daily dose as your basal amount, which is reasonable, right? But the more important thing, again, is that this provides a lot of fodder to start exploring gym habits and hypoglycemia fears. And if you set the alarms, it might give you that confidence you need to start pushing that median downwards, right? If the patient feels secure and safe from lows. Okay. So that was an example of using Libre data, and I've already gone through the 9-step method. More recently, we have this was actually presented by Rich Bergenstahl at ADA this year. So this was just a couple months ago. He showed this new C2GM, so CGM clinician, so C2, CGM clinician guided management, his new algorithm. This is a lot quicker than the 9-step method, and it relies entirely on TBR, time below range, and TIR, time in range. And if you look at time in range, less than or greater than 70%, time below range, less than or greater than 2%, so he uses 2%, not the target 5%, right? Then you can create this 2x2 table, and depending on what category your patient falls into, there are some logical treatment recommendations that follow from that. For one thing, time in range less than 70% indicates you probably need to intensify the treatment. But if the time below range is greater than 2%, you always need to address hypoglycemia first. And if it so happens that your time below range is less than 2% and your time in range is greater than 7%, pat yourself on the back. That's the first upper left quadrant there. Pat yourself on the back. That's the ideal quadrant. You're in a good spot. So that's a much simplified approach, a 2x2 table, time in range, time below range, right? And then if you go to the next slide, if you have a patient on basal insulin, depending on what the category is, this C2GM algorithm gives you some recommendations on things you could do based on where they are in that 2x2 table. this is here for reference. I don't think I'm going to go through it all today, but you'll have a copy of the presentation. You'll probably get a copy of the slides if you want it, and you can have a look at this resource. We'll take the next page. And C2GM provides the same resources for basal bolus insulin users as well, although this gets a little bit more tricky, and Bergenstahl recommends that this be left to a diabetes educator unless you have that kind of time and capacity in your own clinic, right? One thing to bear in mind though, time in range, time below range doesn't tell the whole story. And you might recall our patient earlier actually had minimal time below range, and it was mostly low time in range and high time above range. But it would have been a mistake just to increase that patient's insulin to drive down her sugars. You can see it would have been a hazardous mistake because she would have run a lot lower most of the day, right? So just a word of caution about oversimplifying, right? Again, the AGP, that river diagram, I think is really gold. Okay, now I'm just gonna briefly talk about the things I appreciate, pros and cons about using CGM in practice. A definite pro is that it's provided new insights for my patients. For example, my 80-year-old Asian male who we were struggling to get blood sugars under control on NPH twice a day, had hypoglycemia. I even tried pre-mixed, and then we stuck a CGM on him and realized that he doesn't have a basal insulin problem, not at all. His problem is primarily postprandial, so I was using the wrong insulin. Right now he's on a tiny amount of NPH, and he's on a Humalog, right? So I had to go that way. I had to go MDI in a way, and but that's what he needed to have, right? It was what was safe for him. And then you know, middle-aged female, type 2 diabetes, comes to clinic with an A1C of 11%. That's how she's referred to me. You know, she's not on insulin, but with the Libre, with metformin, with semaglutide, you know, we actually managed to drive her blood sugar down to 5.6% within the first 3 months of meeting her, actually. And a lot of that is her. A lot of that is her looking at her Libre and making those dietary changes in a big, big way. And so that was a bit of empowerment there. She did develop some treatment-induced neuropathy of diabetes. That's a story for another day. So another thing about the Libre is this is post-COVID. It's still COVID era, right? So CGM has made virtual care a lot easier in patients who actually have access to Libre and are using it on their cell phone, for example. And I use Libre because that's the platform I use the most, but I'm sure Dexcom and Medtronic have their own virtual care platforms, right? But it's, you know, I log on, have a look, see everything right in front of me while I'm on the phone with the patient, right? So that's kind of helpful. And the other advantage is, again, you're not stuck on the 90-day wait for the next A1C to titrate therapy anymore. With CGM, if you wanted to, you could wait 2 to 3 weeks and then have a look at the CGM results and then adjust therapy, right? There's not necessarily that need to wait the full 90 days to see what the next A1C is, which is a definite advantage. Okay.
Yeah, and I will add to that, saying that for a lot of my patients using these reports, I teach them how to read their reports, and I suggest they review their reports weekly to make weekly adjustments, because a week is kind of the amount of time that people will remember what happened, and is the kind of time where people are planning ahead for the following week. So weekly review for people who are trying to get their blood sugars under control is something I think that works for a lot of people. And of course, the pros that I just want to highlight, it's less pokey, right? It's convenient, or more convenient than monitoring with finger sticks. A big eye opener for many patients is what is happening overnight or when they're not checking. And so this is a huge, it's a game changer to have that understanding moment to moment. And that understanding builds confidence, and it reinforces the healthier behaviors and negatively reinforces, you know, unhealthy behaviors. And so it really is helpful if people are seeking and open to that feedback.
There are some challenges to integrating CGM into practice. One thing I've discovered is, yes, it's true. If you're using a CGM, let's say you have type 2 diabetes and I'm trying to add on additional medications, but yeah, I don't have to wait 90 days anymore to figure out if I'm going to add the next agent. But on the other hand, neither do I have room in my clinic to see them. There's a new challenge here. Yes, I can titrate people faster, but can I see them fast enough to do it? It is another thing to log into. And yeah, you know, there's a break in my workflow where, oh, you got to log in. What's my password again? Right? Another password. And the other thing to remember is it's only as good as the user. So there are super users out there. There are users of CGM who at the end of the week, they look at their own glucose reports, scratch their head, mull about the trends and decide how they're going to do things the next week to make things better, right? That's a super user. And then there are people who use it as a finger poker replacement infrequently. But on the other hand, you know, I do have a patient who uses it as a finger poker replacement. And she actually goes so far as to do the finger poker, read the measurement, and she writes them into her logbook. It's the sweetest thing. She writes them into her logbook. But this patient actually reviews her logbook and puts a lot of thought into it, figuring out why she went high and does fiddle with her diet afterwards. So in her own way, she's a super user. And maybe the point is there's a diversity of ways of using the Libre, using continuous glucose monitoring. And what we might do for our patients on CGM is to help them get the most value out of it according to their own preferences, right? The most important thing, though, I value CGM because of the new conversations I get to have with people, conversations I didn't used to get to have, right? We get to a mutual understanding of glucose values, and then we get there are more of these aha moments that you kind of live for when you interact with patients with diabetes, right? I think that's what really counts for me.
And just a few other considerations is that for people who are a bit, who perseverate a lot or who get obsessive about their blood sugars, it can worsen their OCD tendencies. And so sometimes it causes more anxiety than it's worth. And sometimes people need to take a break from these devices if they're getting depressed or anxious around the overload of data. They also, you know, while the alarms are good and provide safety, sometimes people do get alarm fatigue, and having the alarms set at the right settings for that individual are very important and need to be reviewed properly if, you know, it's always going off, and that's one of the reasons why they're not using it. But the biggest issue right now for many patients is access and cost. And so they are not covered routinely for adults. So the government did announce that under 18 people with diabetes under the age of 18 will have access to these things. But once they turn 18, they don't have standard access on the standard plans. And another note is that they can develop contact irritation or other issues around the skin real estate required for these devices. So that's something that needs to be managed as well. And lastly, I wanted to mention that the CGM readings can lag behind the capillary blood glucose. On average, it's anywhere from 5 to 9 minutes, but it can lag more or less depending on the sensor. So that is a word of the wise to once again reinforce, if there is a discrepancy between what the patient is sensing and what the meter is reading, they need to do the confirmatory finger poke.
I think this is our opportunity now to tell you about a number of studies that are going on, and then again a plea for help in terms of recruiting patients if you happen to encounter eligible individuals. The first trial I want to mention is one called IQ'd. I know it's spelled funny. It's IQ'd, not ICUD. But this is a trial involving patients with type 2 diabetes who are not on insulin. The point is we have a lot of evidence, small trials to be fair, but it is evidence showing benefits of CGM in adults with type 1 diabetes and adults on insulin. But we have, I think there might be one now that I wasn't aware of before, but we really have a lack of evidence for adults who aren't on insulin at all. And the idea here is, if you have type 2 diabetes, why invest after the fact, after they're on insulin already and have had complications and they've lost 80+% of their beta cell function, right? Is there the opportunity to engage with someone with type 2 diabetes earlier and help them develop insights and adjust lifestyle and diet to avoid progression of their diabetes to the point of requiring insulin? So the point of this trial, I'll take the next slide. We randomized patients to 2 arms. One of them is 6 weeks, so they get 3 complementary FreeStyle Libre 2 sensors, and then 50% of them are randomized to enhanced usual care. And both arms get 2 individualized diabetes educator visits. Of course, the ones in the CGM arm will have some CGM review and advice, and the ones in the non-CGM arm won't have the benefit of the CGM advice. The outcome here is 3-month HbA1c, but we are measuring a number of patient-reported outcomes in the interim at the 6 and 12-week mark. So again, this trial looking at CGM in adults with type 2 diabetes not on insulin, which is a bit of a gap in the evidence, but one we think has a lot of promise, right? If you happen to encounter patients who you think might be eligible, please, please, please send them our way. What you do need to do, though, is you do actually need to explain the study a little bit to them and make sure they're interested, because we can't do the initial screening. It has to be someone in their circle of care. But if you find someone who would be interested, here's how you can get a hold of us. So you can fax their details to that number, leave a voicemail with their details, or if you're on Connect Care, you can send a Connect Care message to myself or to Dr. Yeung. If you want more information on this, please let me know, and I'd be happy to send you our study information package, brochures for your waiting room, a poster, anything you'd like.
We will be sending some of that information with the slides and evaluation. So you will receive all this information summarized, so you don't have to remember it now. But this is a great way to get people who would not be able to get access to that sensor or don't want to pay for that sensor, 3 sensors. And there was a typo on the previous page. It's not 2 sensors, it's 3 sensors. Yeah. So it's a great way to get people, access to this technology through a trial setting for free. So that's something to keep in mind. And we are starting the recruitment now and creating our list. So please do send them our way. Another study that we are recruiting for is run through the DO and SCN. They are offering a free virtual diabetes prevention program for anyone with pre-diabetes. So that's an A1C of 5.7 to 6.4. So if you've got patients with pre-diabetes who want virtual coaching, and it's based on the diabetes prevention program through an online vendor, the DO and SCN, or Diabetes, Obesity, Nutrition Strategic Clinical Network, are partnering with primary care providers to enroll patients in this online coaching intervention, and we'll actually share the data with you, and you can look at their information at their website listed here, or send any inquiries to vdpp@ahs.ca. And lastly, for trial recruitment, I just presented on this 2 weeks ago. And if you're interested in type 2 diabetes remission, you can find our talk on that on the website soon. We are looking for participants 18 to 45 years old with a diagnosis of type 2 diabetes of less than 6 years, not on insulin, with an A1C between 6 and 10%. If there are people interested, we will also send out information on this, as it is a very intensive intervention to achieve remission. It's a very low energy diet and structured exercise, and the study will last 24 weeks. To note that the people in the control group will be waitlisted for the low energy diet meal replacement intervention. They won't get the exercise, but they will get the meal replacement as a waitlist control. So we've included a few slides in the package for additional information and references, and we will open up for questions. Thank you very much.
Thank you so much. We only have a few minutes for questions, but before we move on, I have a number of patients with diabetes, particularly type 2, that don't need to use this all the time, but I do like them to trial it for 2 weeks. And most of them don't have the affordability to buy it. I did find a website that had it. I think it's only the FreeStyle Libre that offers that. But do you know the website? And maybe could you put it in the chat? Patients, they attend an hour video on how to use it. And I found it really helped educate them about their diabetes and control, even though they don't need regular monitoring. And questions we have from Daisy Fung. What's the average weekly cost of diabetic testing supplies, strips, machines, needles compare to the weekly costs of CGMs?
So that really depends on how often they're testing. But if you look at a typical blood glucose strip, that's usually between 75 cents and $1. So if they're testing the suggested 4 to 6 times a day, you're looking at, $40 to $50 just in the strips, let alone all the other things that they need. There is definitely a cost effectiveness question around these devices, and that work is being done, and the results are starting to show that these devices are in fact cost effective. And I would venture to say that we are probably going to see even more cost effectiveness, particularly in our type 1 diabetes patients on pump, when now they have artificial pancreas systems where the pumps can interface with the continuous glucose monitors using automated algorithms to titrate the basal insulin and better adjust for after meals highs and things like this automatically. So I think that these CGMs, like I say, are a major game changer, and I think the cost effectiveness will just be more borne out as time goes on.
Eleanor Stein says, I tried Libre 1 a few years ago to learn about it. And compared to capillary measurements, the Libre 1 was consistently 0.8 lower. Has accuracy improved with the Libre 2 or other trends?
Yes, the accuracy is continuing to be better. And so the other thing that you need to note are things like vitamin C can affect the readings. So if patients are on supplemental amounts of vitamin C, not typically, the dietary amounts, but if they're taking vitamin supplements, that is something that can interfere with the sensor action readings.
And we have a question, is Traceba injected at night by the patient? Is there a difference in injecting in the morning?
The answer to that is probably not. The half-life of insulin degludec is long enough that it shouldn't really matter. And that's actually how it's marketed. It's one of the things the manufacturer will say is, hey, your patient who's doing shift work and can't inject it reliably at a given point of time, give them degludec. Yeah, that's the short answer to that question anyways, is it probably doesn't matter.
And then Daisy asks again, another question, are there any concerns about the accuracy with lows? A low is lower than if measured by blood capillary check.
So I think that the concerns about lows really are more, is there hypoglycemia unawareness going on? And there can be false readings of lows when they can get compression hypoglycemia, which is not true hypoglycemia. When they're, say, sleeping on the sensor, it can cause false lows. So what I advise patients to do is always do the capillary glucose check. And also interpret in light of what symptoms that they are having. So the whole picture needs to be taken into account, and a clinical judgment has to be applied to see whether these lows are really truly low or not really concerning.
The other thing that some of my patients have told me is that the first day they use the sensor, the numbers don't make as much sense as the following days. That may not be a thing for all patients. And in fact, I don't know if this is your experience, Rose, but I do find that there is the occasional patient who just seems to have a lot more problems with how sensors like the Libre perform than the other patients. It might be that some patients just are a little bit more take a little bit more of an accountant or an engineer's approach to it, and actually are always comparing their finger pokers with their Libre, and then they're just unhappy with it. But I feel like I do have a small handful of patients who really do have high deviations of differences between their CGM and their true their capillary blood glucose measurements. And unfortunately, it might be, if it's the sensor, the company's always happy to replace a sensor because those things are bloody expensive. But even with different sensors, sometimes they say it's just really off, and then it's the technology might not be for them, right? But technically, on an average basis, we're talking about a mean absolute relative difference of about 10%, and the number of times, though, that difference has actually led to a change in management, like the difference between giving fast-acting sugar versus not, or increasing a dose of insulin versus not. In the studies that looked at this, the percentage of times that a difference in results has actually made a difference in management is something less than 1%. Like it's pretty small. It's pretty small. But again, that's a statistical average, and there are occasional patients who really do have difficulty with the Libre for reasons that I don't understand, or other CGM too.
And we are at time. We have about 6 questions left. Would you like to answer them after?
Yeah, we certainly can take a look at the questions and send out the answers to the registrants. Thank you so much for your questions. It's really nice to get all these really thoughtful questions. And I'm just going to quickly say, yes, the studies are for Alberta only. In fact, while the Reset to Remission trial is actually also in Montreal and Edmonton are the sites in Canada, but the VDPP and our IQ trial are really only for Alberta. So thank you very, very much for attending tonight.
And thank you to our great presenters.